Good evening, everyone. So today I'll be presenting two cases. I'll not take much time and start my first case. This is a 68-year-old female who was diagnosed with rheumatoid arthritis, who was presented to us in 2011 with 10 years history of inflammatory polyarthralgia and was started on conventional DMARDs for the past 9 years. And on presentation, the patient has ASR CRP high with ANA 3+ with RF being high 397, and ANA profile showed SSA borderline positive with the diagnosis of rheumatoid arthritis with the secondary Sjogren's. We have started her on triple DMARDs, and the patient has attained remission in 2014. So in 2011, the patient was diagnosed with chronic RA with SSA borderline positive, active disease. Triple DMARDs were started. In 24, has attained remission. And 2015 to 2019, the patient was stable and asymptomatic, and plan was to withdraw the drugs. And in 2019, there was a relapse of the joint pains when the patient was on methotrexate 10 mg and hydroxychloroquine. So there was a remission failure and reintroduced with the DMARDs, methotrexate 25 mg and hydroxychloroquine 200 mg. So in 2021, the patient is presented with a 4-month history of diarrhea and blood in the stool, following which colonoscopy was done, which showed cryptitis with crypt abscess, indicator of ulcerative proctocolitis, and started on mesalamine along with the DMARDs. So this persisted, and the mesalamine was increased, and in view of altered bowel habits, persistent altered bowel habits, which has lasted for more than a year and which is associated with a weight loss, she was started on short course of steroids, and which has led to the worsening of the diarrhea episodes with the blood in the stools. So this is a sequence where in 2019 the patient has all normal bowel habits with disease flare, failure to remission, and started on DMARDs, following which in 2020, in the mid-2020, patient has started having diarrheal episodes and was started on mesalamine, which was worsened, and subsequently the mesalamine doses have doses increased and subsequently improved, but again worsened and was started on steroids. Later, in view of worsening diarrhea, stool calprotectin was done, which was more than 50, and USG abdomen was done, which was normal, and stool routine showed plenty of pulses, but the culture being negative. She has underwent again a repeat colonoscopy, which has shown again a suggestion of ulcerative proctocolitis, and biopsy was done this time. So biopsy, it has shown chronic active colitis with intranuclear viral inclusions suggestive of a CMV infection. So following this report, the patient was started on valganciclovir and stopped for 2 weeks and stopped methotrexate for a while. Following which the recent follow-up with us was in December 11th, 2022. She had significant improvement in the bowel frequency of the stool, and she was restarted on methotrexate and continued further to valganciclovir was continued for 2 more weeks. Subsequently, following the biopsy report, we have sent CMV IgM and IgG, both were positive, with blood CMV PCR target not being detected. So coming to my second case, this is a 22-year-old boy who is in follow-up with us since 2014. So he is a 15-year-old boy who was presented to us in 2014 with GTCS episodes, who had a past ongoing skin lesions which are ulcerating papular type since 1 year with associated generalized weakness and low-grade fever. Outside which he was diagnosed to be a PAN and received oral steroids and 4 cycles of cyclophosphamide. Initial workup at our center, it was ANE 1+ spectral pattern with ESR CRP 25 and 1, C3C4 being low and ANCA being negative. Urine routine showed active sediments, that is granular Cas and protein 3 plus, and with ANA profile showing nucleosome positive and dsDNA positive. With MRI drain suggestive of CNS vasculitis, we came to initial diagnosis of SLE with CNS vasculitis and we started on azathioprine, hydroxychloroquine and steroids 0.5 mg per kg per day. So from 2014 to 2017, the disease activity is as follows. So the urine routine in 2015 showed 3 plus proteinuria with granular Cas, and that is when we have started azathioprine, hydroxychloroquine and 0.5 mg per kg steroids. Not to forget, the patient has received 4 cycles of cyclophosphamide outside. So following which the urine routine has improved till 2017 and patient was asymptomatic, and hence we have thought of tapering the azathioprine. Following which, in 2018, the patient had proteinuria of 1 plus with granular Cas, but still asymptomatic, and then the patient was on azathioprine of 50 mg. Coming to, in 2019, the patient had persistent hematuria and proteinuria with low complements, and hence we have got planned for a renal biopsy, and APT, and it was delayed because as the APTT was prolonged and APLA workup was done, which was positive. The APLA showed anti-cardiolipin antibody IgG being positive and IgM being negative. As Renuka ma'am said, IgG is more anti-cardiolipin antibody IgG is more significant, and beta-2 GP, IgG and IgM both being positive and strongly positive for lupus anticoagulant. The renal biopsy was done, which showed lupus nephritis pattern with RPS class 3, activity score being 3 by 24 and chronicity 0 by 2. And patient was started on anticoagulants and has received rituximab. On follow-up, the patient proteinuria is reduced but still persistent. In 2020, the patient didn't turn up for the follow-up, and in 2021 again has come with hematuria and proteinuria. And again, the ANA profile was repeated. It showed again nucleosome equivocal and dsDNA equivocal with C1q strongly positive, and received second dose of rituximab. This time the hematuria reduced, but the proteinuria was still persistent. So now, currently the patient has come admitted with acute pain in abdomen, with burning, micturition and reduced urine output, with loose stools since 3 days and lower limb swelling and fever of low grade since 1 day. He was not compliant with medications since 2 months, and currently the patient was on mycophenolate mofetil 1.5 gram per day, hydroxychloroquine and acetron. So on examination he was febrile, and for abdomen there is diffuse tenderness and patient was drowsy, arousable, obeying commands. And on investigation, we have considered it as SLE flare with the lupus nephritis with secondary infection with acute, probably secondary to UTI and acute gastroenteritis. And the TLC was on the higher side, 27,640 with a neutrophil predominance, and C3 being on the lower side with procal 39, suggestive of a secondary bacterial infection. In hospital, the patient had fever spikes for the next 3 days, and he was started on IV meropenem diuretics and hydrocortisone. And we have sent a CMV, IgM and IgG on the day of admission, following which the report has come to be positive, and we started on valganciclovir on the second day. As on the day 5, the patient was improving, and the renal parameters were normalizing, and culture has grown E. coli, which is sensitive to meropenem. The patient was was symptom free, and we have continued IV antibiotics and valganciclovir and oral steroid, and was discharged with oral antibiotic and steroid and MMF and valganciclovir. Subsequently, we sent a CME PCR which was negative. After the discharge, patient has come for follow-up after 2 weeks, following which there were active urine sediments. No hematuria, but proteinuria was persistent, and we have increased the MMF to 2 gram per day. While going back, he had one episode of GTCS, and he again came back to us, and then we have got an MRI done which showed CNS vasculitis with multiple lacunar ischemic lesions in supra and infratemporal region, and we have increased the prednisolone dose to 1 mg per kg, and continued valganciclovir, and planned for rituximab. Following the rituximab 500 mg, patient is better. So take home message: early diagnosis and treatment improves the quality of life and reduces associated complications and chronicity of the disease. While withdrawing DMARD, we should always keep an eye open on disease flare, and always consider co-infections in disease flare. Ruling out co-infections before opting aggressive treatment will reduce the mortality secondary to infections. Thank you.
Thank you, Dr. Yogitha. A very